from Dr. Mritika Barua, who talked about adaptation. And we discussed in there the importance of fidelity. And we'll be building on that today with Dr. Juliana Kogura. And Juliana is an associate professor in public health at the University of Witwatersrand in South Africa. Her research interests are in non-communicable diseases and epidemiology using life course approaches, and also, of course, by joining us today in this series, implementation research. So I will turn this over to Juliana. I'll be monitoring the chat in case people have questions or logistic issues, and I'll also be posting questions for our ongoing discussion. So please join me in the chat while we hear from Dr. Juliana Kagura. Thank you, and over to you, Juliana.
Can you hear me?
Yep, we can hear you.
Okay, I'm trying to move my slides to see whether they can. Okay, great. Thank you. Thank you so much, Anna, and the Implementation Research Connect platform, the WHO-TDR program, and for this opportunity. And I want to thank everyone who has joined. I think I've got some of my students here. Welcome. All right, so this afternoon we're going to be, or morning, wherever you are, we're going to be talking about implementation fidelity and adaptations in low to middle income countries. So I'll start off with just a generic introduction to implementation fidelity, or fidelity to implementation, as some might put it, and its conceptual underpinnings. So in terms of definitions and conceptualization, and discussion of measurement and monitoring of implementation fidelity during the implementation process. And we'll also look at some aspects of adaptation and the process of adaptation. We also should be also able to relate implementation fidelity to adaptation of evidence-informed innovations. All right. So just to give a bit of a background around implementation fidelity, it's one of the implementation research outcomes within the taxonomy of implementations. And as you know, implementation outcomes are the effect of deliberate actions to enhance integration of evidence-informed innovations into practice in real-life settings. So these are indicators of the implementation success and part of the proximal indicators of implementation processes. So we've got evidence-informed innovations, followed by our implementation strategies, and the implementation strategies lead to intermediate outcomes, which are our implementation research outcomes, followed by service outcomes and health or patient outcomes. Right. So from that, sorry, I'm just can't move my slides. So from that, just expanding on the definition of implementation fidelity, this is the degree to which a program is delivered as planned, according to Christopher Carroll, 2007. And you see in certain publications that adherence is often used as a proxy for implementation fidelity. So, you know, in literature, you find out that fidelity can be defined in various ways. So depending on the type of study, so when you look at program evaluation, sometimes they define it as the extent to which the implementers adhere to program evaluation guidelines. Or when you're talking about efficacious or effectiveness research, we're talking about intervention fidelity. So fidelity to the intervention guideline. So if it's treatment, it's the treatment guideline. But when we are in implementation science, we are mainly talking about the fidelity to the implementation strategies or the implementation processes or the implementation approach in that area. So it also varies according to field of study, as we've told about implementation. Say it could be in mental health, public health, science education. You see that they are varying definitions of implementation fidelity. But in a nutshell, it just talks about was the program or intervention carried out as intended by the program managers or the. Okay, so that takes us to how does implementation fidelity differ from intervention fidelity? From what I've just discussed around the effectiveness research, you see that intervention fidelity is the extent to which a specific intervention is delivered or implemented as planned within the controlled settings. So in intervention fidelity, we are mainly talking about controlled studies, the efficacy studies or the effectiveness. So being, making sure that the control group and the experimental groups, they receive the intervention or instructions exactly as described in the study protocol. When it comes to implementation fidelity, here we are talking about the degree to which the programs or strategies are implemented and or scaled up as planned in real life setting or in team settings. So while intervention fidelity refers to the degree to which a specific intervention is implemented as intended in controlled setting, just to remind you of what we said in the previous slide. So in implementation research, the interest is in the implementation fidelity, while in effectiveness research, the focus is mainly on intervention fidelity. The experimental or the control group is intervention according to, or no intervention according to study protocol. Right. Just looking at the conceptualization of implementation fidelity, Carroll 2006 framework depict an evidence-informed intervention as pass through a vehicle which we call implementation to the point where we get the program outcomes or the health outcomes which you are interested in. But in is the how the program is being implemented in terms of fidelity or adherence to the program guidelines or the protocols. So the aspects of fidelity or adherence comprise of content, that is the active ingredients, e.g. this could be skills if you are looking into training. This could be the drug specifications if you're going to be implementing, say, a mass drug administration within a certain setting. And then coverage. This is talking to the number of recipients receiving the intervention. So in this case, it could be a strategy. Say you are training people. How many people have you trained on this, on delivering this intervention? In terms of frequency, now we're talking about the number of sessions being part of that strategy. It's training. And duration, the length of each session, or it could be the duration which the population or that particular setting is exposed to that strategy, right? But they also acknowledged that there are potential moderators which which come in the pathway of implementing an intervention in a real life setting. These include the complexity of the intervention. How difficult or easy is it to use this intervention? Or facilitation strategies. What kind of strategies do you use to facilitate the implementation of this intervention in real settings? And the quality of delivery. So quality, I know people might say quality is subjective, but is per given protocol, have you delivered this with quality? So those are some of the moderators, including participant responsiveness. How are the participants taking this implementation or of this intervention? And some contextual factors, which may be individual, or it could be inner setting, outer setting, contextual factors. So that's the conceptualization of implementation fidelity. And we move on to measurements now. So in terms of implementation fidelity, there are a number of measurement tools that have been proposed in the literature, including also approaches. But one which stood out for me was the one proposed by Philly in 2018. So there are 5 steps which they have brought forward in this paper by Philly. Firstly, looking at the definition and scope, or the definition of scope and the purpose of the fidelity assessment. So why are we doing the assessment of fidelity? So you also have to state the level at which fidelity assessment has to be done. Is it happening at individual, organizational level, provider level, and who exactly is going to be the participant in this when we are measuring fidelity? And we need also to be able to describe the aim. What is the purpose and the relevance of fidelity assessment in this program, in the scope? So to what extent are we measuring fidelity in this program? Secondly, we need to identify which ones are the essential components. As we know, with evidence-informed innovations, we've got the core components, the ones that you can't compromise on those, and you can't change those ones. And we also have the non-essential or the adaptable components, which you can modify to fit into the local context without impacting program effectiveness. So it's important to identify what are our essential or active ingredients, which are directly linked to the positive outcomes and program effectiveness. So depending on the evidence-informed innovation, the measurement of fidelity may focus on one component of adherence instead of all components. So that might be a key point to note, especially if you look at the conceptualization of fidelity. You might choose to look at maybe reach, or you might want to look at content. You might also want to look at any of those 4 components of adherence. Thirdly, you need to now develop a fidelity measurement tool. And you can use a criteria that include the following steps. So first, you need to compile a customized detailed list of content items and process items in terms of the program that you are implementing. And consider the quality and utility of existing validated tools for similar intervention. So you can go look up the fidelity of implementation rating systems that have been used elsewhere, and you can also draw a checklist from treatment manuals or guidelines. I remember in the time past, we used to also use some literature around surgical checklist. So you are able to derive your fidelity instrument from the surgical checklist. Has this been done, yes or no? Just to make sure that the surgeons, they adhere to guidelines. And then next, phrasing of items. You have a clear set of items measuring one component of fidelity. So that's important to have clearly defined items in terms of your measurement tool and the response choices. You have to, are you going to use a binary response choice or a head scale or a rating scale, 0 to 10 in terms of different components of fidelity? And after you have compiled, say, your measurement tool, or you have taken one of the existing validated tool, you need to pilot test it within your context. And this might be an iterative process of testing until there is 90% agreement. I know this is a high target to achieve, but it's important that you pilot test that too. Fourthly, the fourth step is you need to now monitor it. So you've piloted your tool, and now you're going to use this tool to kind of measure fidelity within your setting. So you need to start monitoring fidelity and rating through observation, or it could be self-reporting, or it could be video or recording. So the rating process should be as random as possible to ensure reliability of that tool, but also for you to be able to kind of generalize within that set. So raters should be trained for consistency in terms of scoring, where you're using a rating score, and scoring for some components of fidelity, again, should reach above 90% agreement. I think for some of us who have used measurement instruments for other things, we understand thus the rating agreement. So finally, we are also interested in using the fidelity measure in terms of analysis. So the fidelity assessment ratings and monitoring can now be used in outcome evaluation. So we might be interested in understanding the association between the extent of implementation fidelity and a health outcome. We might also be interested in understanding the factors that affect implementation fidelity. So it can be used as a moderator of the relationship between the intervention and the related outcomes, or it can actually be used as an outcome, or in other cases as an exposure, where we've got a clinical outcome or a service outcome in person. So in summary, what we are saying is fidelity is one of the implementation research outcomes, and it's important in implementation research, real-life setting, while intervention fidelity is about adherence to evidence-informed innovations protocol in effectiveness studies in controlled settings. And the conceptual underpinnings of fidelity highlight the moderating role of fidelity and its own moderators in the relationship between the intervention and our ultimate outcomes. So measurement of fidelity should be done in a systematic manner that enhances validity of the results. So obviously, from what we've discussed, adaptations with high fidelity are important for program effectiveness. So we move on to look at the adaptations, because there is need to balance adaptations and fidelity as we implement various strategies in our context. So I've illustrated this with kind of a balancing scale, adaptation of evidence-informed innovations versus fidelity equal to program effectiveness. So there is need for easing the tension between fidelity and adaptation. To balance between these two, there are several frameworks that are available in the literature to guide the adaptation process of evidence-informed innovations to fit a new or a different context, while it's minimizing the changes that could negatively affect program effectiveness. So, with adaptation of evidence-informed innovations, what is it? It is the process of modifying key characteristics of the intervention, recommended activities or delivery methods without competing with or contradicting the core elements, theory or internal logic of the intervention thought most likely to produce the intervention's main effect. So in other words, what we are saying here is we are modifying the key characteristics of an innovation, but not compromising on the core or active ingredients of the evidence-informed innovation. So there are two forms of adaptation. First, you can modify the program content. These are changes incorporated into the protocol or manual to suit the needs of our end users or consumers. Or you can modify program delivery. So these are the changes related to characteristics of the delivery person. So you can say we are moving from nurses to lay workers, or we are equipping caregivers with enough skills to be able to administer certain medication instead of them being practitioner delivered. So those are modifications in terms of program delivery. So examples of adaptation frameworks include the FRAME by Stearman in 2019. I will not go into the details of this in the interest of time. You can look up that reference. The STEP framework, the ADAPT framework, and the adaptation framework based on the EPIS framework by Mosian in 2019. So for this presentation, I'll cover the adaptation framework based on the EPIS framework. EPIS stands for exploration, preparation, implementation, and sustainment, mainly talking to the implementation process. So here is the adaptation framework, which describes 11 steps in terms of adaptation. And the steps were compiled according to the EPIS framework, as I've said, and this indicates that this could be an iterative kind of process. So there is a back and forth kind of approach to adapting evidence-informed innovations. So you start off with the exploration phase, where you have the initial assessment. So you look at what is happening on the ground. It could be a situation assessment or a needs assessment. And then you look at the evidence-informed innovation and say, where can we adapt in this case? And then you select the intervention and you explore in terms of the key components or the active ingredients versus the ones that are adaptable, right? Then in the preparation stage, this is where you talk about strategies in an ordinary EPIS framework. But here you now look at the identification of possible mismatches, all right? So I think let me just go through the processes in detail. So we're talking about the exploration phase, and I gave a brief summary about this. Let's go to the second stage, which is the preparation phase, where we say we need to identify potential mismatches and any adaptation concerns in terms of mismatches, barriers to implementation, and participation from the recipients or the stakeholders. And you then need to kind of develop a logic model and a plan for implementation. So the logic model mainly talks about, what kind of activities, what kind of uh, results do you expect, and the inputs, the processes, the outcomes which you expect to get. And then we move on to look at stakeholder engagement within that preparation phase, where you consult with advisory board, community planning groups in that context and setting, and identify stakeholders who can champion the program adoption, and also to be able to ensure program fidelity. So the third phase is the implementation phase. So now you have to develop the adaptation plan based on your logic framework of the activities, the inputs, the processes, and the outcomes, and adapt the original program content, including any cultural or social kind of environmental adaptations that have to be made, ensuring the ease retention of fidelity to the core elements. And then you move on to pilot testing. This is more like pre-testing the adapted material with stakeholder groups, including pilot testing the adapted innovation in the new setting. And remember, this is where we say you have to come up with a 90% agreement in terms of your measurement instrument. And then you also now need to refine the adaptations, incorporating the stakeholder as feedback and finalizing the implementation plan, and then you implement the adapted intervention. The last phase actually includes the monitoring, the maintenance, and the evaluation of the implementation. So here we are mainly talking about the process, the outcome evaluation, ongoing supervision to make sure that if there are any further adaptations that need to happen, like as you said, it's an iterative process. So you might have to go back again, go to phase one where you kind of adapt the adaptable components, and then you pilot again, and then you move on with ongoing monitoring. And then the maintenance mainly it's to establish and implement a kind of a dissemination plan that you have for the adapted innovation. So these are the kind of the 11 steps that talks to the EPIS-based adaptation framework. But if you go back to the other frameworks, you will note that some of these steps, they are condensed together into 4 or 5 steps in terms of assess, design, implement, etc. Okay. So let's look at a case study in terms of adaptations and implementation fidelity. Is part of our just a case study from a low to middle income country. So this is my favorite one from Burkina Faso, and look at the evaluation of implementation fidelity of seasonal malaria chemoprevention intervention in Kaya district, health district in Burkina Faso. So they used the CAROS framework and also added some aspects of ASAM ITAL 2012 into that framework, mainly by adding a number of contextual factors. And the study design there was a mixture of qualitative data and quantitative data. So it was a mixed method study. And quantitative data was mainly on coverage of the SMC strategy, while the qualitative data was semi-structured interviews and in-depth interviews with key informants, right? And the measurement of fidelity was the number of activities that were implemented as part of the SMC strategy divided by the number of activities for each component of that strategy. And the essential ingredients were drug administration, including dosage, training, and supply, And the adaptive components were behavioral change communication strategies to address the gaps in advocacy and door-to-door activities and the M&E plan. The major rationale for adaptations, excuse me, were to fit the local context, the door-to-door versus community delivery, societal acceptance around the chemo prevention, especially the parents and using the parents for drug administration compared to healthcare workers. And they also employed a direct observation therapy for the parents and to monitor the children in terms of taking the chemo prevention. So that's it in terms of a case study. As part of your reflection, what are some of your experiences in terms of adapting evidence-informed innovations and measuring fidelity? And in that breath, what were some of the essential and adaptive components, and which measurement tools have you used before? And were there any potential limitations in terms of the construct or the measurement of implementation fidelity in your work? Those are just some reflection questions which you can answer. I thank you. Thanks, Anna.
Thank you so much, Juliana. Actually, could you go back to that reflection slide? I think this might be helpful because in the chat, there were some questions around specific examples, largely walking through the process that you had outlined previously. And so I wonder if before we get to that, if maybe we could ask you to reflect on these questions. So what has been some of your own experiences in adapting and measuring fidelity? What was essential? I know you just shared with us the Burkina Faso example, but can you think of some others to really help ground the audience and the concepts that you've just presented over the last 30 minutes?
Oh, great. Thanks, Anna. So we've had projects in various countries from part of our MSc students projects. And one of them was implementation fidelity around I'm just checking here. I just want to make sure that I get the terminologies right, because as you know, I'm not an expert in NTDs. But this student was looking at implementation fidelity to dispensing guidelines for praziquantel drug. I think it's for schistosomiasis. And what they noted was, the key ingredients in terms of, or the active ingredients, they were, the treatment guidelines in terms of how often and what actually should be, how, they should be, prescribed within pharmacies. So that was more of the active ingredient. And the adaptable ingredients or component where do they have to run like pharmacy based deliveries, or they can actually give to certain programs that were schistosomiasis prevention campaigns within the endemic areas in Zimbabwe. So those were the essential and the adaptable components. So whoever was, licensed to be able to deliver those drugs, be it programs or pharmacies, they had to adhere to the dosage, to the treatment guidelines as the core components. But the mode of delivery was mainly the adaptable component. And in terms of the measurement tool, what we ended up using was, a tool that was developed from scratch. So we took the components of adherence, the content, the dose, the frequency, and all that. And then within that, we had questions that we asked, which were mainly the rating scale on a scale 0 to 10. How did the pharmacists implemented those guidelines? And from there, the student piloted this tool, and we ended up getting around an 88% agreement, mainly because one, the way the questions were asked. So we ended up changing the questions in the phase 2 of the piloting until we got almost to 90%. We're very close. I think we moved to 89.9, something like that. So rounded up to 90%. And from there, we came up with a quantitative measure of implementation fidelity. And the moderators were also part of that measurement. So there were also quantitative measures. And within the same measurement tool, the limitations was, the response rate, because this was during lockdown. So the questionnaires would be sent, electronic version follow-up. But we ended up having, from the database of pharmacists, we only had about 76% response rate, which we didn't expect this, since this was an online tool. And the other problem we noted was some of the constructs were not applicable to this kind of a research question. So in terms of participant responsiveness, we did not interview or send the tool to the participants, but rather it was mainly the perception of the pharmacists, which we felt this was not appropriate. So we took out participant responsiveness. We are working on the final draft of the manuscript to publish, but that will be an interesting read.
Absolutely. I was just about to ask you if there was a publication that I could share with our participants today, but it's great to know that you're working on that final draft now. And Juliana, that was a really helpful example to think through those different components, the testing process, maybe doing adaptations until you're getting to that 90%. So that was really helpful. There's a question in the chat from Maria, who asks, can you provide a specific example of how to evaluate the quality of delivery of this strategy? What type of measurement tools are available that can be used for quality?
Okay, that's an interesting question. So in terms of quality of delivery, in our case, what we were looking at is timeliness. So there are different measures depending on, your research question. So, and also the context in which you are working in. So one of the things that we noted in terms of another study which another student was working on was the training. So the quality of delivery came from the perception by the end users in terms of, were the sessions done on time, in terms of the training material, easy to read, something like that. So these again were items that were borrowed, I think, from assessment of an educational tool for physical activity that was being now adapted and being kind of piloted, with some changes in terms of that tool within a TB drug administration program. I hope I've answered.
Yeah, thank you, Juliana. I'm also looking now to see if I can find some resources online on measurements around quality. And I just stumbled on a scoping review of measures for quality, specifically on health behavior change interventions. And I'll put that in the chat I don't know, I wasn't able to actually read through that article, so I'm not sure how useful it is, but the title at first glance might be of value as we think about measuring quality. Um, Maybe also, Juliana, I'd ask you to reflect on this last question that you posed in the reflection. What do you see as the limitations in your own experience of the construction and measurements that you've used to measure fidelity?
Thanks, Anna. So I think the tricky about looking at implementation research is it's context specific. So we are taking and selecting some of the aspects around, say, participant responsiveness, quality of delivery from our context. So the fear is how generalizable is this? Can someone use the same items that I've selected and use to ask in within the same research question, but in a different context? And what kind of, is it reliable enough within the other context? So those are some of the subjective nature of measuring implementation fidelity. That makes it difficult even to collect, systematic reviews, like wanting to do a meta-analysis on implementation fidelity, because the scoring is different. Yes, you might have a quantitative measure, but the scoring might be different. The context might be different. The number of constructs added, instead of the 4 constructs, someone might use 2, frequency and dosage, and leave the other ones. So in that case, it becomes a bit complicated, or a limitation on its own.
Thank you. I think throughout this series, we've really been exploring the role of context and how it influences our implementation strategies, how we design those strategies when we think about evidence-based approaches. Last week, Dr. Phyllis was talking about the ingredients of evidence-informed interventions, right? Thinking about the content, the pedagogy, and the delivery, all of which are areas where we can be thinking about fidelity, but also might need to be thinking about adaptation as well. So there's a lot of measurement and a lot of moving pieces as well. I want to open us back up to audience questions. I mean, maybe Juliana, if you want to reflect on that last statement, please feel free, and then we can see if the audience has any additional questions for you today.
Yeah, so while you're checking the questions, I just wanted also to add in terms of the potential limitations and complications around measurement instruments is, I think once you get 90% agreement in terms of your items, and you have tested, the pilot tested this, and you've seen that it's working within your context, you can at least, be at ease, knowing that you have ticked all the boxes in terms of what is expected of you in terms of validity of these measurement tools.
Thank you. I see Gloria has a question. Please join us, unmute.
Yes, thank you. Can you listen to me?
Yes.
Okay, thank you. Good morning from Colombia. So I think I have a doubt about how you interpret the use of implementation strategies to adapt intervention. So what is the relationship? Because you have an intervention in which you have core elements that you don't wish to change, otherwise you change the effectiveness. But at the same time, you have to use implementation strategies to implement that intervention. So what is the role that implementation strategies have in the adaptation of the intervention when you are going to deliver the intervention? Hope that is clear.
Liana, was that clear?
Yes, the initial part was quite clear in terms of we are using an implementation strategy to deliver an intervention. So she was the last bit where she asked about adaptations. I didn't pick that one, Gloria. If you could go again for the last bit.
So basically, you have to adapt the implementation strategy. That's my question. So when you are
Yes.
adapting, what you want to adapt is the implementation strategy. Is that right?
Yes.
Okay.
Yes.
Thank you. Yeah.
All right, yeah, so you're right, Gloria. So what we want to adapt is the implementation strategy, which in some cases, including the example that I've given, that framework, they are looking at the implementation intervention. So the implementation intervention is your implementation strategy. So when you are putting up this for adaptation, what are the core elements? What are the the adaptable components of that strategy? So with the example that we gave, the SMC strategy, you saw that some of the adaptable components were actually behavioral change strategies. So they were the strategy around, communications in terms of advocating for this chemo prevention. So it wasn't the chemo prevention itself, but it was, adaptation to the strategies that they were given. So the essential ingredients were the way you administer the intervention, including dosage, training, and the supply chain. So something like that.
Okay. Sure.
Yeah.
Thank you. Mm-hmm.
Thank you for that. Yeah.
Juliana, we have another question in the chat about monitoring. And in the presentation, you mentioned a little bit about observation and also the rating process. Can you elaborate a bit more on these, especially this cutoff point of the 90% in the rating process?
Oh, okay. Yes. Thanks for that question. I think I mentioned something around how, the last stage is you need to be able to monitor and evaluate your implementation and making sure that, fidelity is maintained. So with your the monitoring and evaluation of, say, implementation fidelity, you can do an ethnographic observation. So you are seeing how people are implementing this. And so that's a study. That's what I mean by observations there. You can also have a implementation fidelity checklist where you've got that rating, right? You can also, I haven't used the other qualitative, study methods beyond ethnographic observations. So that's why I've given those as examples, the ones I've used. So the fidelity checklists, the healthcare, the healthcare provider can then check, was this done in the case of the surgical checklist, as an example, or, procedures within practice, are these also incorporated with them? Some people actually use records so they can do documents. I have a student who is looking at stroke rehabilitation. She's currently using a document review to just check whether things have been done according to, protocol for rehabilitation.
Great. And can you talk again about this 90% agreement cutoff rate as well?
Okay, so remember I mentioned around the issue around the measurement instrument. So we've got the instrument itself. So in terms of when you pilot, you have to get the 90% agreement in terms of enhancing reliability of that tool. But you might also have different measures in terms of your assessment. So be it a subjective scoring mechanism, and for the same process, do we have like, are we having the same assessment as between individuals, assessors? So whilst we might think if fidelity in this case was 60% through an observation and scoring, someone might assess the same procedure and think it's 20%. So we need to have kind of an agreement even against various measurers or observers. That was my 90% agreement. And I think it applies to other research areas as well.
Thank you. I'm not seeing any other questions. Maybe I'll just give a moment to see if there's a hand or another question in the chat. In the meantime, I'll just announce, we have our session next week again on May 28th, and we'll be discussing gaps in implementation research measurement, continuing to build on this conversation and look at other implementation research outcomes. So please join us at the same time for the session next week. Juliana, it doesn't look like we have any additional questions, so let me just please thank you for your time and engagement today, and thank you everyone who joined us on this discussion of fidelity and adaptation. When you log off of the session today, you will have a pop-up, a short evaluation. Please do complete that, and we hope to see you next week as well. So thank you all. Juliana, again, thank you for your time today.
Great, thank you everyone.
Thank you everyone. See you next week.
Thank you so much. Thank you.